SARS-CoV-2 is still a killer virus, and that the pandemic is accelerating worldwide. Every day there is a new record. The number of cases announced yesterday by WHO exceeded 900,000 cases, and we are getting to 1 million cases per day, with 480,000. It is also clear that the epidemic is still to the extent contained in Lebanon. And this is based on not only the number of new cases and active clusters, but also the number of patients admitted to hospitals, to ICU, and the number of patients using respirators, and the number of tests. So let us consider the factors that have that have contributed to control the disease in Lebanon. And I would like first, my slides are moving. Martin, can you share the slides, because I'm not able to run my slides.
Can you try again now sharing PowerPoint? Share application and PowerPoint if you have opened the PowerPoint on your computer as we did before. I think the issue is that you are logged in on two devices, maybe the phone and the laptop. So now you're back to sharing content. Okay.
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 I'm sorry for that. So let us consider the factors that have contributed to control the disease in Lebanon. I would like first to highlight the importance of preparedness. Over the past 2 decades, we have been building our outbreak capacity at the Ministry of Public Health, because such pandemic was expected and we're waiting for it. And these are the most important benchmarks. We created an epidemiological surveillance unit in 1994, decentralized in 2005. And we have developed our first contingency plan at the time of SARS in 2002. And the last update was the preparedness and response for COVID-19 in February this year. We built our core capacity to meet the requirement of the international health regulations, and we had a joint external evaluation in 2000. And we trained hospitals with collaboration with WHO in 2009 to develop their contingency plans. And we started building capacity at Rafi'i Hariri Hospital, because we learned from the pandemic that we cannot count on private hospitals in case of pandemic. So we built our laboratory capacity, and we have created an isolation unit that is called Ebola, because it was done in 2015. So our strategy was to flatten the curve and to enhance the capacity of the health system. What we did is on January 30, so these are the measures that were taken by the Ministry of Public Health. With the declaration of fake by WHO, we activated our surveillance system for the novel coronavirus. We initiated following up on travelers coming from endemic countries, particularly China at that time, the airplane, and we got 450 persons coming from China. 2 of them came from Wuhan and were quarantined, if you remember, at the Harir Hospital. February 20, we felt that something suspicious is happening in Iran, knowing that in February 19, the number of cases reported by Iran to WHO was 0. But because we were alert, we went to the airplane coming from Iran, and we discovered the first case of COVID-19. And I think this was determinant because it gave a sign of alarm to all people, pilgrims, thousands of them that were coming from Iran to be quarantined at home. And then we started admitting all the positive cases at hospitals, even those that were asymptomatic. And of course, we started case investigation, contact tracing, and of contacts. These the measures taken by the government, the lockdown measures that were introduced progressively. And the most important one is the travel restrictions, as we will see later. This slide is to compare the lockdown measures taken by different countries in the region. And as we can see that Lebanon is not among the strictest one. I'm saying that because we overemphasize the importance of lockdown measures compared with the containment. Well, at that time, we set the bar at 5,000 cases, and we considered that the capacity of the system, particularly the hospital sector, can accommodate the needs of this number. And considering this scale, this is where we are now. We have 1,622 cases, 5 to 6 active clusters, and 32 deaths. And this is to give you an idea about the case fatality rate, 2.1% on average, and of course it is around 4% for the age group 50 to 70, and more than 60% for those about that are above 70. Because we were having a limited capacity for testing at that time, we were testing only cases fitting the case definition, i.e. those that are having symptoms and coming from endemic countries. Since April 1st, we decided to be more aggressive and to test all repatriates, testing to all persons with respiratory symptoms, systematic testing of all possible contacts, field testing in localities where a local index case or sporadic cases are identified, and field testing in crowded, vulnerable settings and targeting frontliners. As you may notice that in real life, decision making is not solely based on theories, and most often it is dictated such as international shortage supplies. We wanted to isolate every single positive case, and I'm talking about isolation, those with symptoms in hospitals or in community isolation centers for asymptomatic cases. But this is still a weakness up till now. We couldn't really this policy because most of the isolation centers are not yet active. So by increasing the number of tests, this shows that we have moved from few hundreds per day to more than 2,000. And the maximum we could reach was 2,450 tests per day. And this is still not considering the expected number of travelers with the of the so looking at the epidemic curve, what do we see? I don't see, I see spikes, and I don't see a correlation, a direct correlation with the progressive of lockdown measures. And to compare with another country from the region, this is the example of Pakistan when they lifted the restrictions on May 9. We can see the progressive increase that became exponential with the progressive lifting of lockdown measures. This is not the case of Lebanon. So, however, we can see a direct correlation between the number of cases among travelers and the number of local cases. So we are rather affected by the lifting of travel restrictions. And this is what is the most worrying for us. And if we consider the three groups of repatriates, I don't have yet data about the fourth group that came last week. But if we consider, let us focus on the third group, 14 to 30 May. We had 10,866 passengers, among which 707 were tested at the airport because they came without PCR results. So we didn't test those that came with PCR negative. And we had 1.48% that were positive. However, we took a sample from the negative cases among the 6,814 passengers with negative PCR. We retested 713, and we discovered that among them 13 positive. This that we probably missed over 100 cases that are false negative. And these cases are unknown, and if they do not respect the isolation or the quarantine because they are considered negative. So some of these cases will become clusters. And if the number exceeds our containment capacity, they will be transformed into community transmission. And this is the danger. So we are in phase 3. I would 4 sets of measures for suppression. The first one is related to personal hygiene and self-protection measures. The second is related to epidemiological surveillance. The third is about response measures to break the chains of transmission. And the fourth one is about the imposed social distancing, lockdown measures, including flight restrictions. So to make for the disease, for transmission, we need the presence of the circulating viruses, meaning infected persons, and contacts. So if we have people interacting together and no one of them is infected, there is no risk. So our policy would be either we isolate every citizen avoid contact by imposing lockdown measures, or we can isolate all positive cases so the virus would not be circulating. But this needs to be aggressive in cases and testing and making sure that positive cases are strictly institutionally isolated. So with the government, if we look at the upper half of the slide, the government was acting on 2 components, lockdown measures to avoid contacts among citizens and travel restrictions. And now they have decided to lift the lockdown and at the same time to allow importing cases from abroad, injecting new people infected in the country. So this decision is already taken by the. Now, what we should do? Well, we should first on people behavior to adopt personal protective measures and physical distancing. And this needs community engagement. And I believe this is, do you hear me? Hello?
Yes, we can hear you. If you can please wrap up in 2 minutes.
Okay. So this is a weakness regarding the community engagement. And on the other hand, we should enhance our containment capacity for testing, tracing, isolating, care for cases, quarantine, and follow-up. What is important is that the number of new cases and clusters should remain within our containment capacity. So we should keep a steady state of low transmission and remain ready to control sporadic cases and clusters, have a close observation of transmission amplifiers, and the MOPH should continue on a daily basis the epidemic curve, cases characteristics, and the evolution of chain of transmission and clusters. And the capacity should be scaled up. If we consider the epidemic risks, we have at the left side of the screen. To our side, we have the age pyramid with large lung population, the expected seasonality of the virus, the good institutional capability for containment. We have trained personnel and qualified labs, and most importantly, the low endemicity in the country. This means that we have a low virus load resulting from good containment and personnel protective measures. What is a high risk for us is the lack of community engagement, high population density in certain localities with limited access to clean water and sanitation. It's coming from countries with higher endemicity than Lebanon, and limited containment capacity in terms of number of staff. We have qualified staff, but we don't have enough number to meet the expected needs with the opening up of the airport. And also, we have limited supply in terms, particularly swabs and lab reagents. And the non-operational community-based isolation is an important issue. So what we need to do is to make these isolation centers operational. And we cannot count on volunteers to face the next phase, because we have a high number of volunteers helping us, particularly at the port. These volunteers should be recruited and injected in the system to enhance its capacity. And the number of travelers should remain within the outbreak capacity. So I will stop here.
Sorry, I had trouble unmuting. Thank you very much, Dr. Ammar. We will move without further ado to Dr. Petra Khouri. I'm just giving you the privileges of the presenter. I will introduce you very briefly so that we can start with your talk. Dr. Petra Khouri obtained her doctor in pharmacy degree from the Lebanese American University in Beirut and subsequently completed pharmacy residency program at Massachusetts General Hospital, MGH, Harvard University in Boston, where she specialized in infectious diseases, and thereafter she completed the Quality Safety Leadership and Informatics program at Harvard Medical School. After working at MGH for years, she moved to Lebanon a few years ago and assumed an executive role at the American University of Beirut Medical Center. She currently works as Chief Quality and Compliance Officer at the American University of Beirut Medical Center, and her role involves providing oversight over quality, safety, risk management, medical legal, accreditations, and regulatory compliance, and pharmacy department. She currently serves as advisor to the Prime Minister of Lebanon on health-related matters, and as I mentioned earlier, she was heavily involved in the COVID-19 response. The floor is yours, Petra, to talk about lockdown release and Lebanon's response.
Thank you, Martin. Good morning, everyone. So in the next couple of slides, I'm going to go high-level information about how did we go about the COVID response in Lebanon and the strategies for lifting the lockdown. So just a little bit of a background. The COVID National Committee was appointed on January 31st. The first case arrived confirmed in Lebanon was on February 21st. So a couple of weeks before we had the first case, the National Committee had started its meetings, and we started discussing strategies on what needs to be done and started the infrastructure for the response. Initially, the goal of the response was, from the beginning, it was a whole government response. We had decided from the beginning, since the government has very limited resources, and given the healthcare system situation and the population situation that we had in Lebanon, 5 million Lebanese with 2 million between displaced and refugees, the resources were we had the liquidity issues, we had some civil unrest going on in the country. So our buyer's power was very limited. So we had to hit early and hard. That was the strategy in the committee from the beginning when we sat down. The strength of the committee, it was a multi-sectoral committee. It contained from different sectors, health and non-health care, in addition to the fact that it was a private and a public sector committee. A lot of the members on the table came from the private sector, simply because the healthcare system also shoulders on the private sector, in addition to the other sectors, the tourism, the other sectors, the trading. So everybody had to be on board so that we have a successful outcome. So it was a whole government response. The goal of it was to minimize the health and social impacts on the people. And from the beginning, we wanted to limit the transmission. We knew that if this becomes an outbreak and all across the country, the outcomes would be detrimental. So Dr. Ammar mentioned planning started for containment and mitigation. And eventually we put in place what is needed for an emergency state, which is what we got to on the way. This is the structure. We had 9 pillars that we worked off. The National COVID Committee was heading the different pillars, and every pillar had an entity responsible for it, and under every pillar, the ministries involved were working together. The committee was receiving from the different ministries that were represented on the table updates on the progress of all of these pillars. And the committee was meeting around 5 to 6 times a week, probably on daily basis, to get updates and progress on what was happening across the board with every pillar, and making recommendations and pushing agendas where it needs to be pushed. So in summary, what did the committee do? We were 35 members. However, we had lots of invitees. We were bringing lots of guests, and a lot of decisions were made. After every meeting, we made recommendations. These were not, some of them were a little bit operational, but most of them were strategic decisions. The National Committee also had subcommittees. These subcommittees had 200 members in them, and they were split in different, depending on the topic. So the containment planning was the subcommittee basically got feedback from the Ministry of Health, where they had all the work done there to identify, test, trace, treat, isolate. There was a section where a lot of the preparedness came in place, building capacities with hospitals and labs, and because the committee also had the private sector around the table, so a lot of input was given there. Mitigation planning, we had a task force that was put together to discuss in an event that we go into mitigation and the numbers spike up beyond the capacity of the healthcare system. What do we do? So we identified sites, field hospitals that could be built. These hospitals, field hospitals or sites, the manuals for them were made. And along this came the issue of medical ethics. We had a subcommittee to discuss medical ethics to support the healthcare workers in the event of difficult decisions had to be made by prioritizing healthcare. How do they do it? That subcommittee had the judicial, the lawyers. It had ethicists in it. Quarantine sites, we had a subcommittee that visited isolation sites. Around 100 sites were inspected across the country. 43 were selected, and 19 are currently under renovation out of the 43, part of phase 1. A lot of attention was given to the refugees and migrant workers and the displaced because of concerns that these are underserved, overpopulated communities, very vulnerable communities. And we were concerned that if an outbreak starts in these areas, it might start as a wildfire across the country. Another arm was sectors planning. Like I mentioned, when the country was shut down, a lot of sectors stopped running, the non-essential ones. And so once we started talking about reopening, many things had to be discussed with these sectors. With the essential sectors, before the lockdown, we had marathon meetings, around 4 days meetings, how we can keep the basic essentials running while the lockdown is there, from gasoline to food services, to manufacturing, to healthcare, to pharmacies. So a lot of meetings were done there to maintain ports even. And so the sector's planning took a lot of effort and time from the committee. And national communication was one of the key issues into this response plan. And the Sarai had devised a unit, emergency unit in the Sarai that is operational 24/7. The Ministry of Health issues a daily report, and then there is another report based on the Ministry of Health that is issued at the end of the day that combines the Ministry of Interior Affairs report, Ministry of Foreign Affairs, the situation on the ground. So it was a full report, 360 of what's happening in the COVID response across the country. Awareness campaigns. I think one of the successful things and that happened in this in the early phases of COVID is the awareness that was launched across the media. The TV stations had hosted a large number of physicians and healthcare providers that spoke about COVID and elevated the awareness across the country. Also, the prime time in the news and after the news, the programs, they were dedicated for this. Add to it the social media, the messaging, and the fact that this was a pandemic also helped increase awareness and interest among the public. There was a subcommittee that discussed repatriation and the airport closure and reopening. Repatriation, as Dr. Ammar mentioned earlier, was 4 phases. After every phase, there was an evaluation and a decision about the next phase was made. The airport decision of reopening has taken so far 3 to 4 meetings so that we can open on July 1st. Many things have been put in place and still are under works. Today, they start the private jets arrivals. The one thing that we wanted to keep and encourage people to come to Lebanon was related to not having to quarantine people for 14 days when they're coming here for a couple of days or weeks. So, sort of a medical testing protocol was established of having 2 PCRs testing that are more than 72 hours apart would most likely minimize the likelihood of somebody being positive and circulating around if they're not quarantined. So that we ended up using this standard to encourage people to come over, but at the same time not have to quarantine them. The last one was related to sustainability and monitoring when we reopen the sectors. And this is the most difficult one. The committee sat with most of the sectors when we discussed reopening, and I'll get to that in a few on the next slide. But the sustaining the measures in the industries was the most difficult one. So ministries, of course, are involved. Municipalities are involved. Interior security forces are involved. We created also volunteers layers. Students from universities, we established a platform for them where they would sign up for becoming a volunteer in their community. So we created a community service volunteer to go around the districts where they live, check on the sectors, check if the sectors are applying what needs to be applied. Early on, the volunteers were able to handle the volume when we were gradually reopening. However, with the reopening, the total reopening of the country as we stand today, these volunteers are overwhelmed. And that's that's the gap that we're trying to fill out. One, by a social responsibility, bringing it back to the owners of the industries and asking them to re-implement the measures and the guidelines that were issued by the Ministry of Labor. The occupational health sector had issued guidelines, and so most of the sectors had taken ownership, but along the way the economical pressure had pushed these measures aside. So this is the challenge we're having today: is how do we reach out to these sectors again and rediscuss with them. We do not wish to close any sector, but at the same time, these mass gatherings are risk of super spreader events. And so we are now in discussions, how do we reach out to them? The volunteers are not able to keep up with the speed. And so in this subcommittee, this is the type of discussion that we're having. So this is also the response in another way, non-healthcare, healthcare, as I just mentioned, contingency planning approach, and the plan evolved as we went along. So the scenarios that were put in place initially by WHO gave us some best case scenario, second best case scenario, and the most probable scenario. And according to these figures, the committee looked at the key challenges that we have. Like I mentioned earlier, we had limited healthcare capacity. We had limited financial resources. The most important issue was the health behavioral change that we had to impose on the community and the society. Misinformation and disinformation. This is a new virus. Many information was circulated on the media. Most of it was fake. A lot of it was just somebody sitting behind a computer and putting a piece of opinion that people started taking to heart and following. So we had to have an aggressive communication campaign, and the management of overcrowded areas. We also prioritize. Procurement came as a priority. MOH had taken the lead on that. As we know that this was a pandemic, so we were competing with countries that had much more resources than we had, countries that had larger buyer's power. So this was a big challenge. MOH had to couple its effort with the World Bank and WHO in maintaining the supplies and maintaining the flow of PPEs and testing, ventilators, and procurement of the essential needs. Like I mentioned, there was a marry between a public and private partnership, which in my opinion was one of the key success of this response, because there was a sharing of responsibility and ownership. And it was not kicking a responsibility across the table. It was actually both partnered in making this a success. The non-healthcare sector, the socio-economical support, when we went to a lockdown, a lot of people are paid by per diem, and many people lost their jobs along the way. So this was a priority that we had highlighted. And the business continuity, services, utility, law and order, and logistics. The socio-economical impact was one of those that came later along the way when we discussed reopening the country, given that, like I mentioned, Lebanon's macroeconomic stability, and as we all know, the dear situation of our economical status. So resources required were split, healthcare and non-healthcare. We discussed shortages, healthcare coverage. None of the healthcare insurances had agreed at the beginning to cover a pandemic. However, along the way, we had meetings with the health insurances, and they offered to cover testing, creating regional testing site. Building capacity was one of the key issues, because it was not just about having a hospital ready from a physical standpoint, but also the training its personnel, quarantine sites, supply chain. The non-healthcare sector, shortages in consumable, supporting low-income families, support the per diem labor, compensation for occupational health exposure, time off. Initially, when a healthcare worker got infected, they were taking time off of their own. So this was a point that was discussed. Supporting municipalities, crisis management units were done across all governorates in the country, and they were feeding back the committee, liquidity, financing the purchases, and supply chain across the board. This is in a nutshell all the key decisions that we're taking. I'm not going to go over them all, but across the board, we kept the pushing for decisions to support the plan and keeping it on track. The reopening strategy, how did we reopen? We had, we used a model. We estimated the risk of transmission based on contact intensity, number of contacts, and modification potential of the business. And at the same time, based on economic impact, how badly it is needed, and the financial consequences. And accordingly, the economic impact and the risk of transmission level were combined, and phases were distributed. Phase 1, phase 2, phase 3, phase 4, and phase 5. Finally, where are we today? Dr. Ammar mentioned, but this is just in summary. We are at 1622 cases. Total recovery is 1098. The number of PCR tests completed so far are 118,000. Total death 32. Hospitalized are 54 cases, 9 ICU of them, and 3 intubated. We are still in containment. We have not gotten to the widespread of cases. Just one more point that I'd like to mention here is with the reopening of the country, we started seeing some clusters in overcrowded areas. And yesterday, during our last meeting in the evening, the COVID committee, we had discussed, we actively have 5 clusters that are not under control yet. And all 5 are in overcrowded areas, most likely related to the lowering the guard with the protective measures, and people going back to some normalcy. And this is the fear of when we reopen, what happens if people lower their guard in terms of safety measures. Thank you.
Thank you very much, Petra, for this very interesting presentation. I bet many people attending did not know the amount of effort and work that has gone into this response at the national level, and I'm sure it will raise a number of questions. The floor is now open for questions. I have one on the chat. Aline is telling me that she sent a couple more, but I can't see them. So if you can please either take turn in saying them directly or write them in the chat for all. The first question by Michelle Abisad. She's saying we are all proud of the tremendous work that has been done so far. On the other hand, the media is conveying the message that the government has contained the problem and the general population feels that the risk is non-existing, whereas the origin of few clusters is still unknown, and one of them is next to a camp. Can you comment on that, and when are you expecting a second wave? I guess that's for either of you.
Dr. Ammar, you want to take that?
Yes, yes. Well, thank you for the question. We are very worried that people are not they are not anymore afraid of this virus. This is why I highlighted the fact that this virus is still deadly and the pandemic is accelerating worldwide. And there are some opinion that we heard on the media about the virus losing potency, or about people in Lebanon or Arabs genetically immune or protected. Or all these are unfounded, and we should explain to the population that the situation is under control, because the problem is within our capacity. Once we will be having a number of cases in the cluster that exceeds our capacity, we'll be having an acceleration of the disease, and that will become exponential and out of control. And Petra mentioned the fact that we have cases in crowded area, and the case index is not identified, and this is worrying. The first group we had from Iran, these were pilgrims, very well organized, disciplined, and this was really helpful for us. The second group we had from Europe, these were people educated from high income category, and they were cooperative, and they had the possibility and the capability to isolate themselves. Now we are getting more and more people that are poor, in poor areas, low education level, and living in crowded areas. So we have a high risk, and this should be communicated to the population, and to explain that the pandemic is not over, and we should really be careful on I'm not talking about a second wave that eventually would have it in fall, but now we didn't finish with the first wave, so we can have a rapid increase of cases. This is why it's important to activate the isolation centers and isolate every single positive case, and at the same time enhance our capacity to contain the disease.
Thank you, Dr. Ammar. Another few questions from Aline Germani. I will combine the first two, then mention the third. What are the challenges or barriers for implementing institutional isolation, and how feasible it is to implement forced isolation on all travelers?
Shall I take that, Dr. Ammar?
Yes, please.
So I mean, travelers should not be considered as infected people. They're not. Forced isolation or forced quarantine is usually done for those that are positive. What we're trying to do with them is now, because the quarantine, and it's everywhere in the world, the numbers are huge. You cannot quarantine thousands. We've so far repatriated around 20,000. And we expect much more. When we're talking 2,000 a day as of July, we're talking about 60,000 a month. So it's impossible to quarantine all of these numbers. So the idea here, and this was the discussion in the meeting in the committee, is what do we do, because it's impossible to quarantine all of these people. That's where the idea came of having 2 PCR negative. The likelihood of them being carriers of the disease would be very minimal. What was the other question?
Yes, I think you answered it. There's also a related question before I move on to another question. Mabel On is asking, why are we allowing visitors from Qatar in July, knowing that it has the highest number of cases per million population?
Sure. So who do we allow to come to Lebanon was also one of the discussions when we decided to reopen the airport. Dr. Ammar mentioned an important point. Lebanon is the lowest infected country. Any place that is going to come, any country that we're going to open, they're going to be at the higher infectious standpoint from Lebanon, whether it is Qatar, Kuwait, Saudi Arabia, UAE, France, Italy, UK. All of these countries have moved into mitigation phase. They're no longer in containment, and so it doesn't matter which country. What matters is the measures that we're going to apply, because all of these countries now are in mitigation. They're not in containment, while we are in containment.
Thank you. Another question also by Aline. Taking into consideration lack of enforcement capacity of the government, how can industries and specifically restaurants be monitored regarding implementation of public health measures?
Yeah, I did touch on that. The volunteers that we had recruited, they have an application, and we built all the infrastructure with the Red Cross, but it's not enough. So this is one of the discussions. If people have ideas, we would welcome them. This is one of the issues, the challenges that we are currently discussing at the table in the committee. How can we reinforce these measures back on not just the restaurants, but everything? If you watch the beaches over the weekend, they were overcrowded. And I mean, the malls, they're not yet overcrowded, but there is a worry that every sector that we're opening, eventually they're dropping the guards because of economical pressure, and they're loosening up.
From Rana Abdel Malak, what are the measures to keep Lebanon in containment phase? I think part of this was
Dr.
already
Ammar.
answered.
Dr. Ammar can take that.
Dr. Ammar can maybe add to it.
Yes. Well, as I explained, if we are having, particularly from abroad, positive cases that are within our capacity of containment, we have no problem. And let me highlight the importance of the isolation centers at this particular phase. The isolation centers were not intended to serve when we have a community transmission. At that time, we would be having thousands of cases that we cannot accommodate within hospitals and isolation centers. the total capacity up till now, hospitals, in addition to isolation centers, does not exceed 2,500 persons. It is really very, very important to use them at this stage. We missed the opportunity to lower the number of cases to 0 if we were capable to isolate every single positive case. And now we can still do it before opening the airport in order to maintain the situation within our capacity. So this is an issue of regulating the income of positive cases, the coming of positive cases to the country within the capacity of the Ministry of Health.
Thank you, Dr. Ammar. We'll take 5 more minutes since there are quite a number of questions. Also, Rana Abdul Malik is asking whether there's a specific number that determines when we exceed our capacity. Is it a number of cases or a number of cases? I'm trying to elaborate a little bit, maybe number of cases hospitalized. So is there like a threshold where you know already this is beyond our capacity, or this is where we start not being able to deal with?
Yeah, you know, we were at the beginning, we were emphasizing on increasing the capacity of hospital care. All the other countries did the same. And now we discover, because we were not sure of our capacity to contain the disease, we were sure that we will be having a big outbreak with exponential increase of cases, and we were our fear was to go to the mitigation phase and to have hospital capacity that is capable to do all the cases. Where now, according to our experience, since we were really efficient in our containment strategy, and we were able to contain the epidemic, we should not miss the opportunity. Now we should take it seriously to talk about enhancing the containment capacity, the outbreak control capacity, testing, finding cases, investigation, isolation, and the quarantine of contacts. Since we have the capacity to do this, we should neglect this phase and prepare to a more dangerous phase that we can avoid now. I'm saying, my point is that in addition to enhancing the capacity of hospitals, we should and we can enhance our capacity for containment. We have a lot of volunteers that are working with us for months now. We cannot continue like that. These volunteers should be injected within the system, and we should use these isolation centers.
Okay, I would please urge you to keep your answers short. We have already exceeded time, but there are a few other questions. From Hamad Alamuddin, there are scientific reports on the low probability of children to both contract and pass the virus. What is the thinking in regards to reopening schools in the next academic year?
Do you want me to take that?
Yes,
go ahead.
Okay. So we had 2 sessions with the Minister of Education and other education, other people in the education sector, and the discussion now has been, and now if we want to reopen, how do we reopen? I think that the idea, we have to reopen. We all said that multiple times. The fear is, how do we reopen and what do we have to do at schools? The daycare issue came up. We reopened daycares. The latest study that Muhammad just mentioned about the risk of transmission among kids, less than 50%, is reassuring. This is something that we will discuss in our next meetings to prepare for the fall reopening of schools. But definitely behavioral changes at schools have to be implemented, because schools are also have workforces that are not just kids. We know that a lot of the teachers probably are mid-aged, so the risk is there, not just. And then there's the public transportation, the buses, and transporting kids through buses. Maybe this is a vector there by itself. So these are all the things that we would think about.
I think, Khawla, you have your questions answered. From Farouk Abu Hassan, what is the government's plan if a surge in the number of cases occur and cases become out of control? And what are the factors that will force the government to impose another lockdown?
If the current 5 clusters and beyond the other new clusters pop up in the next couple of weeks, and we can't control them, I mean, like every other country, when they started their healthcare system started to fail and unable to treat its population, that's when we have to reclose.
Okay, and from Samar Nuruddin, do we have the manpower to hire in case we need to use the quarantine sites?
Yes, we do. This is being worked out with the UN agencies.
Okay, from Peggy Hanna, what are the indicators you are relying on to assess and measure community engagement and in the process?
There were 2 surveys presented at the committee, part of the communication plan, where we received some feedback on the different districts in Lebanon, the different governorates, and that's how we started and continue to reach out to communities.
Okay, final 2 questions. Also from Peggy Hanna, regarding the national committees, RCCE was clearly mentioned and not simply public communication. So 2 distinct areas that should not be diluted. The interagency working group is doing an amazing job that I'm using as success story and best practices regionally. I think that's a comment and not a question. The final question from Rachel Tesh, what was the expertise tapped upon, not names of persons, but specialties to make decisions within the National COVID-19 Committee? And what are the channels of communication with the committee, and how is the collaboration between the public and private hospitals ensured? 3 in 1.
Okay, so depending on the topic, we chose the leaders in that field. So if we're talking about the airport, we would get the people in the aviation industry, we would get the commercial airlines on the table, and we discuss and we do a global review of what's happening elsewhere, and then we adopt what can be adopted, and we change what needs to be changed. So in every depending on the topic, that's my answer. Depending on the topic, we were inviting the best in the field. The next one was what was the next one?
On the coordination between the public and private hospitals.
It worked very well, I can say that. I mean, Dr. Ammar probably can speak more about that, because he had them multiple times at the Ministry of Health. And in my opinion, at the table, at the National Committee, it was one team. It was never 2 teams.
Okay. Peggy is clarifying that it was actually a question, not a comment, asking about whether you are separating this communication from public communication. So because you only mentioned public communication in your action plan.
We communicated basically in our briefings. We were putting everything out there, even the risks, and at the end of the minutes of the committees are published on the website. People can have access to all of them.
All right. Last question from Tracy Saber. Are there any legal sanctions for private events where safety measures aren't applied?
Yes.
And whether these are enforced?
Yes, there are. Whether they are enforced or not, that's part of the Ministry of Interior Affairs, but there are.
Okay, there's a couple of questions left in the chat. I don't think we can extend beyond this. We will save the chat along with the recording and send the link again for everyone to listen. And if you don't mind, Petra and Walid, looking at the chat again just to cover the questions that weren't answered, maybe in writing.
Martin, seems you got disconnected, right? Dr. Ammar, can you hear me? Hello?
You're now the host.
Hello. Hello, Petra.
Hi.
Let us have a meeting.
Actually, apparently Martin was disconnected, but unfortunately, I'm on a regular participant because I had a problem in joining the panelists link, so I cannot see the questions. Were you answering?
We were wrapping up. We were actually wrapping up.
There was a question you were answering?
No. We were wrapping up. That's it. We're done.
Okay, Dr. Ammar, would you like to say something at the end? Dr. Ammar?
No, I have nothing to add. I will see if there are further questions. Maybe we can reply to them later on.
Okay. Dr. Khouri, anything to add?
No, thank you so much for hosting this event.
Okay, thank you, Dr. Ammar and Dr. Khouri, and thank you everyone for your participation. Thank you. Have a nice day.
Thank you. Bye-bye.